Yeah. So, good morning. I'm little late for the class today because the pen drive is not working properly, so I need to shift to another pen drive. So, I am myself Dr. Naveen Singh, Assistant Professor in Department of Dentistry. So, today's topic, what I am going to discuss is about maxillofacial trauma. So, any injury that occurs in the maxillary mandibular facial region, okay, that is to be considered today, and how it is managed and what are the factors that are responsible for causing maxillofacial trauma. Why maxillofacial trauma is of most important thing. So before I start, I just wanted to show you what is the epidemiological incidence of happening of maxillofacial trauma. So out of we taken 1 million cases of any trauma, out of which 50, any trauma. So individual 50% of incidence is in maxillofacial region. Okay, so 0.5% is in the maxillofacial region, and unfortunately, there is no two-way conversation. Actually, I wanted to ask you people, like, where is the more incidence or predilection of causing maxillofacial trauma, in males or in females? So common answer is it is in males. So why males are more prone for maxillofacial trauma? Because of their aggressive nature, fighting, roaming around, not that much self-caring and all those things. There are n number of factors which I am not going to discuss, but male predilection is more than that of the female. Though nowadays the incident ratio is almost near to near. So if I take 10-20 years back, the incidence was around 70 to 30% in male and female. But recent studies have shown like 55% of male and 45% of female have maxillofacial trauma because of nature, aggressiveness, lifestyle, and all those things are causing a lot of maxillofacial trauma. What are the causes of maxillofacial trauma? More commonly, you might have heard it's RTA, road traffic accident. Nowadays people move outside easily, on bike, on car, improper driving, road rage, disputes, trauma, and many things. So causes are more. Pediatric predilection is also there compared to why? Because the children's, they do not know where the danger is, so they also undergo this maxillofacial trauma. General consideration, head and neck region. As you might have seen so many movies or might have heard, what is the first thing we need to protect when you are undergoing any trauma or accident? Before accident, suppose someone is in flight or someone is in car or someone is in train, and all of a sudden you find that after a couple of time you may encounter an accident. So at that instant, the first thing what we need to protect is your head and neck region. Why head and neck region? Because anything happens to this region, is fatality is 100%. Fatality is 100%. If suppose you have any problem with it, you lost your legs, you lost your hands, you lost thorax region also, I mean to say you got an injury into thorax region also, stomach region, it is some level, it is manageable. But if you see in head and neck region, anything happens, fatality is 100%. Neck is gone, all connections, your heart doesn't beat properly, no proper signals from the brain to your lungs, your heart, your kidney, all the organs dies off. Okay, excluding your brain, but after some time it also get affected and the patient undergo coma. So head and neck region is the most common area to be considered when we come across with certain trauma. Now coming to when you encountered a trauma, what things to be taken care. So the ABCD, most of you might be knowing what is when you encounter a patient. As soon as you see the patient, you need to follow ABCD rule. Now what is ABCD rule? So now AE stands for airway obstruction. Okay, look, any airway obstruction is there, so maintain the patency of the air. Okay, so usually if you see a trauma, most of the people get crowded. Try to make that space clear for the air. Okay, in that locality or in that perception of situation, maintain the airway patency. Okay, second, check for the breathing. Okay, B stands for breathing. So check for the breathing, whether the breathing is there, breathing is not there, breathing is not there. Then respiratory recession has to be taken. Okay, resuscitation has to be taken care so that breathing can be improved. Third thing, you need to check for the circulatory system, the cardiac heartbeat, pulse, and your circulatory system should be maintained, or patency should be maintained. Any loss of blood circulation has to be controlled, and then check for the dilatation of the pupil, condition of the patient. All those things stands with ABCD, and then lastly the soft tissue management. Okay, coming to the history and physical examination. So history and physical examination of any patient has to be taken consideration before starting the treatment, because the causing factor of the condition is most important. Okay, so in my perception or my experience, I have encountered n number of trauma, especially road traffic accidents, because my college where I was studying, there it was on highway, and that highway was considered to be the deadliest highway in India. That was from LB Nagar to Nalgonda. That was Marketpalli where I was studying. So that time when I was studying and when I was doing a job in maxillofacial department, that time I found that most of the cases are from trauma. So we need to take the history. Now what is the need to take the history? So for my case, I am telling an example. Like one patient reported to our department saying that he was driving a truck and the whole truck went into the bushes and there was a tree flanks. All those tree flanks pierced his skin, face, everywhere, and he lost some of his teeth. Okay, that is not that important. So that in that condition he has major trauma on his face, neck, skin, but why teeth? Now that's why. Why? Because the teeth, when he lost, the one of the teeth, because of the branch of the teeth, pushed the teeth deep inside his neck completely, and it was in the pharyngeal region, into the soft tissue, and almost hardly some centimeter away from spinal cord. Okay, so and major blood vessels and nerve. So luckily he was saved. So history is of importance to rectify what the patient has how the patient has undergone this trauma and what could be done. Okay, one more case, my personal experience I am telling you. Patient walked into the dental department properly. He met with an accident. It was a very mild accident. He doesn't had any major symptoms and signs. Okay, signs were less, but symptoms were there. And then when after some time the patient collapsed, and it was looking like as if he was nothing has happened. He had just maxillary fracture, and it was class 1 maxillary fracture, and there was a Gorinson positive. It was a very minor fracture, but internally there was internal hemorrhage occurring into his brain, and in a span of 2-3 years the patient was not there. He is gone. So history is important. Then physical examination, most important. Once the patient reported to the dental office, examine the patient. What things has been happened. Okay. So how do you do examination? By inspection, palpation, and assessing the function of that particular structure. So one thing remember, major I have seen so many cases. So on that experience I can tell you, those patients who has less trauma on their hands, legs, and the other part of the body, but their head or neck region got affected, the chances of survival was very less than compared to those patients entire hand, legs, everything was in pieces completely. They have taken entire load on their hands and legs. Those people where tendency of survival was very much high. Okay, so proper examination of the patient, palpate the area and then assess whether that area is functional or not. Now coming to the maxillofacial region, what functional assessment needs to be recorded is that patient speech, mastication, patient ability to respond back to the stimuli, all those things has to be taken care of. Now, how do you examine? Because whenever the patient reported to the dental office with maxillofacial trauma, definitely he has other complications also. After completely coming back, the last department what is taken care is the maxillofacial mandibular fracture, maxillary fracture, and all those things. And that up to that period of time, there is huge swelling. So assessing the fracture is difficult. Okay, assessing the fracture, assessing the functionality is difficult because of huge trauma. As you can see the previous pictures, you can see here, because of the lot of swelling into the maxillofacial region, the maxillary and mandibular fracture assessment is very much difficult. Okay. So how do we investigate? We take investigations like radiographic examination. Now in that radiographic examination, the most common type or the basic type is panoramic view or OPG, orthopanoramic view. The other type of like the facial plane, the lateral facial examination, the temporomandibular view, jughandle view, the submental vertex view, all those views of X-rays are taken on the conjugate with that of the CT scan. So CT scan is computer tomographic examination of entire structure with 2 to 3 mm of section with soft and axial bone defects can be easily predictable during examination with the help of CT scan. Okay, now this is an OPG, and in this OPG you can clearly see that there is a parasymphysis fracture assisting from the right side of the face, that is the what we usually in dentistry call it as the fourth quadrant. Last time when you have gone through my classes, introduction classes, we divide the maxillary and mandibular region into 4 quadrants: the upper right, upper left, lower right and lower left. The upper right is first quadrant, the counterpart is the second quadrant. The lower left quadrant is the third quadrant, and the lower right again back is the fourth quadrant. So first and the fourth are on right side, and second and third on the left side of the quadrant. So as you can see, the fourth quadrant means, what I mean to say is the lower right back quadrant. You can see there is a fracture line. Now this fracture line is an oblique fracture line which is very much prominent and we consider into an favorable condition. Now what are favorable and unfavorable fractures, which we are going to come in later class. Now special radiographic examination, certain times it is required, like angiography, okay, barium soling and esophagram and MRI scan. All those things helps in determining the obstruction in the soft tissue. Okay, now coming to the major fracture, the predilection of fracture is more in mandible than in the maxilla. What could be the reason? So mandibular bone, last class temporomandibular joint, we have read that mandibular bone is a dynamic bone. It moves. So mandibular bone is the frontal bone, always protecting your important facial structure. It is just like a bumper of your car. So any fracture that occurs, maximum blow is taken by the mandibular bone. Okay, why? Because when you fall, your head, first mandibular part comes in contact. So mandibular fracture is in common ratio. Okay, so more common mandibular fracture seen in younger individual. Now why younger individual mandibular fracture? What could be the reason? Nowadays everyone wants a good bike. A good bike in our time, and this time is different now. Now the sportive bike is a good bike. Okay, only 1 or 2 members can sit, maximum horsepower, lot of speed, but control is 0. Okay, like a KTM, what type of bikes? So recent article you might have seen before this COVID incident, that KTM bike owners or the person who have purchased the bike out of which 60% has met with an accident, 60%, and out of which 30% were major trauma, out of which 20 were fatal. Okay, so 60% of predilection of only one single vehicle. So imagine the most common problem is bike riding, motor vehicle accident. Then comes the sports. I don't think so in India this sport incidence is very much less. Why? Because in India the sports activity is not taken as a major consideration, whereas in other countries it is. Okay, and then comes the gunshot injury, again because of what you can say is like gunshot injury, gun culture in US and all other countries. There is a lot of gun culture. So in India the accessibility to gun is very much less, so gunshot injuries are less. Most common fracture sites. Okay, now where could be the most common fracture occurs, now which we will be discussing in detail, so I am not going to discuss right now. The other factors which are responsible for the mandibular fractures, what could be the other fracture other than assault, motorcycle accident, RTA, road traffic accident, sports, gunshot injury is impacted tooth. Don't forget, most of the impacted tooth which are mesially angulated or horizontal, the wisdom tooth. The wisdom tooth is getting impacted. Okay, the impacted, and then they move in very weird direction. So 90% of the bone is being occupied with the tooth rather than that of the bone. So what happens means only the 10-20% of whatever the bone is left. Any single blow, minor blow also causes a fracture. Okay. Second thing, osteoporosis. Indian women are more commonly affecting with osteoporosis because of nutrition and plus less exposure to sunlight. They also develop easily mandibular fracture. Now edentulous area, that is where dentate and edentate patient, both dentate patient have less predilection to fracture, whereas in edentate or edentulous area where there is no dentate teeth are present tends to develop more fracture. And then comes the pathology, tumor, cyst, lesions, all those things causes lot of fracture. Okay, why? Because they grow into the bone, they eat lot of anatomical structure, there is a loss and structural integrity of the osseous structure, which will lead to easy fracture of mandibular bone. Now coming to the site, what are the sites of mandibular fracture? So mandibular fracture is classified, one of the classification is depending upon its site or its location. So it could be symphysis fracture, parasymphysis fracture. Any fracture that occurs in the midline is symphysis fracture. Any fracture that occurs at the region of the body is called as body fracture. So the ratio of occurring of fracture are more in condylar and body region than compared to the symphysis and angular region. As in angular region, 20% you can see there is a fracture. This angular region is the most common cause of angular region is the impacted tooth or cyst. Give me a second, I'll just talk. I'll just come back. Okay. Amma. Hello. డిస్టర్బెన్స్ అవుతున్నాయి అక్కడ క్లాస్లో. తర్వాత వచ్చేసి చేయండి మీరు condylar fracture, ramus fracture, angle fracture, alveolar bone fracture. As you can see, the coronoid fracture and alveolus fractures are least in percentage because these tendency of getting fracture to this area is very much minimal. You have to have a instrumental blow. Okay, the direction of the rod or any instrument that is coming to injure you, that will lead to this type of fracture. Otherwise, very common fractures are what we can see is condylar fracture followed by body fracture, symphysis fracture and angular fracture. Okay, any fracture that occurs in the coronoid process, see you can, this is a condylar fracture. So condylar fracture very easily, very commonly and very common type of fracture. 36% of the fractures are all composed of condylar region. Then comes the body fracture, because major part of the mandibular bone is body region. So the area of tendency of taking up the blow is more common in the body region of the mandible. Then comes the symphysis region. The symphysis region is the central part of the, so any injury into the frontal region will cause a symphysis. And lastly, angular I have already told you, angle fracture is very much seen in what condition? In any impacted tooth associated with any conditions like cyst, development of cyst, tumor, granuloma, amyloblastoma. All these pathological lesions will cause fracture of the mandible. Okay. So as we have already discussed, classification of the site, the symphysis and parasymphysis fracture, body, ramus, coronoid process, condylar process, alveolar process and angle fracture. So this in dark line demarcation determines the fracture line, which are differentiating a fracture or classifying the fracture into that particular site, which may be unilateral or bilateral. Okay. Coming to favorability of the fracture. Now fractures are considered to be favorable and unfavorable. Now what is favorable fracture? Favorable fracture is that fracture which occurs. There is a fracture line, but there is no detachment of the bone or the displacement of the bony fragment from its location. Okay, so completely after fracture the mandible is completely moved into the another direction, or the condyle is moved into another direction, or there is a missing in the part of a bone structure which was used to help the adjoinment of the both structure is not there now. So these type of fractures are considered to be a unfavorable fracture. Okay, unfavorable fracture. Favorable fractures are those fractures like green stick fracture you can take, or fracture which has occurred but it has not caused displacement of the bone. So the bone there is a fracture, but they are adjacent to each other. They are just near to the proximity. They are not detached. They are not very far away. They are just near, and they do not require a completely exposure of the fracture site and treating the patient by a closed reduction technique. It is possible. Now the treatment modality I am going to come to. Closed reduction and open reduction we will discuss later on. So you just need to know that any fracture which are considered to be in favorable condition, all those favorable type of condition fractures are considered as in proximity to each other, and it can be treated easily with closed reduction instead of a open reduction procedure. So as you can see in this, now favorable and unfavorable fracture, what could be the reason behind it? Okay, the reason is the major and minor muscle attachment. If suppose weaker muscles are attached, favorable fracture, and any fracture occurs in that region, the major muscles will have a tendency to equilibrate the fragment segment into its original position, which won't lead to unfavorable condition. So as you can see here, this is unfavorable fracture. The fracture has taken place and the entire maxillary segment, mandibular segment is completely moved in upward direction. This is in upward direction, whereas the mandible, the remaining part of the mandibular bone is in lower direction. So what could be the reason why? Because the muscles, there are two muscles here. You can see this is the mesenteric muscle, and from the other side it will be median pterygoid muscle. So they are the major or stronger muscles. What they have led to they have pulled the entire fragment segment in upward direction. Because of its slinging action, it pulled the mandible completely into upward direction. Whereas in second image you can see this is a favorable fracture. Now in this favorable fracture, what has happened is that the fracture line is obliquely into the frontal direction, which is obstructing the movement of the mandibular bone in upward direction because of the fracture line. Second thing is that the major muscles are not involved, are not getting involved because of the direction of the fracture. Now in the coaxial view, what we can see here is that the fracture has occurred at the body region, and there is a displacement of the bone medially and laterally. So medially and laterally. And in this favorable fracture, you can see the displacement of the bone is contradicted by the direction of the fracture line. So in this second image is what you can lower image you can see the mandibular bone is trying to move in lateral direction, whereas the remaining part of the fracture is the ramus of the mandible is trying to move to the medial direction. So both the fracture directions are interlocking each other, causing the fracture to be in favorable condition. Okay, so here again unfavorable fracture because of symphysis, both the mandible got separated into two halves. Okay, parasymphysis fracture in this condition because of the presence of adjacent tissue which has not involved during the fracture has maintained the integrity of the bone and its structure. Okay, so one more examination you can see images, you can see this is favorable, this is unfavorable tooth. Because of this favorable part the fracture is oblique, it is not moving in upward direction because of the remnant part is locking the part to move in upward direction, whereas in this type of fracture the oblique fracture, here this is oblique, that is oblique, but in image up you can see the oblique fracture is disto-inferiorly, whereas in this unfavorable fracture the fracture line is transmitting mesio-inferiorly. So because of mesio-inferior movement fracture line, the segment has moved in upward direction. Okay, so that is what I just now discussed, like anterior muscles are weaker muscles. Now what are the weaker muscles? The floor of the mouth, which is mylohyoid muscle, completely occupying the floor of the mouth. So mylohyoid muscle is a weaker muscle. It is just need to cover the floor of the mouth and prevent the foot preventing the foot from underlying submandibular gland, sublingual gland, and associated muscles. Genioid muscle, genioglossus muscle, genioid muscle from genial tubercle of the mandibular bone to hyoid bone it is attached, which is another weaker muscle. Genioglossus muscle little bit more prominent compared to the other muscles, but it's having it do not have that much big tendency of movement, hence genioglossus platysma anterior digastric muscle, whereas the posterior is a thick band of the muscle. So in that, and the muscle action depressor and retraction also plays a mandibular movement. So muscle action which are depressor and retraction muscle. The retraction muscles are more compared to the distraction muscle. Okay, depression muscle. So that will also cause movement of the mandible. Now coming to the posterior muscle, stronger force, temporalis muscle, mesenteric muscle, median pterygoid muscle, and lateral pterygoid muscle. These are the stronger muscles. So all these are the muscles of mastication. Last class in temporomandibular joint we have discussed that temporalis, masseter, median pterygoid, and lateral pterygoid is original and insertion. So hope so you people are knowing where it's located and how they are plays a very important role in movement of the mandible. Okay, so these are all muscles. You can see this is an anterior digastric muscle. Okay, and anterior belly of digastric muscle, the mylohyoid muscle. Okay, is attachment. This is favorable, this is unfavorable. Okay, classification by types of fracture. Now what are the types of fracture? So open versus closed. Okay, some fractures which are open, which some are closed. Now any fracture has occurred, but there is no prominent evidence clinically seen. Radiographically it is evident that there is a fracture, that is called as a closed fracture. A fracture where our entire bone or the structure detachment is visible, they are considered to be in an open type of fracture. Now what are the fracture pattern? Now commuted fracture, oblique, transverse, spiral, and green stick fracture. So green stick type of fracture, commuted, oblique, transfer, and spiral, it is basic fracture classes you might have come across in your inter, second, or your B.D.S first year, M.B.B.S first year, second year. So I hope you people may be knowing. Green stick fracture is one fracture which occurs in small children because of least calcification or lesser calcification and more organic matrix present will take up lot of load, and the fracture do not get detached from the bone because of its organic part and attachment of the fracture. So the fracture is slightly hanging like a green stick. When you try to break it, it won't get detached. Whereas a dry stick of a plant, if you try to break, it may break and it will get detached. So the same thing is happening once you are getting into adult, your bone is more. Now one more thing here, the male and female predilection also, most of the time what we have found was when at the same distance and at the same level a male and a female jumps. Okay, I'm not telling you to do this experiment, but don't do it at your home. So the same incident, when it was analyzed and it was found that male bones are more calcified, the tendency of getting more fracture in males are more than that of the female, because female bones are less calcified than that of the male bones. Okay. Okay, so that is a good and bad part. And then the pathology like fracture due to secondary bony diseases, osteoporosis, osteogenic tumors, and all those factors. Pardon me. Now you can see this is a single fracture. Okay, single fracture. This is a green stick fracture. The fracture has not moved from through and through to the bicortical plate of the mandibular bone. When it is bicortical plate and it is a single line, it is called a single fracture. When if it is a multiple line, it is compound fracture. And when the fracture has occurred but it has not caused detachment of the bone because of the underlying soft tissue or matrix, that is called as green stick fracture and comminuted fracture, where the fragments of the fracture segments have been taken and it is in a pieces form. Okay. Now dental classification of fracture is like class 1, class 2 and class 3. So what is dental classification? Why it is called as dental classification? Because fracture in dentate patient, fracture in partially edentulous patient, fracture in completely edentulous patient. Okay. So that is where class 1, class 2 and class 3 is taken into consideration. Class 1 is a fracture where the teeth are, all the set of teeth are present in the dentition, in the mouth, and there is a fracture has occurred. Now class 2 fracture is the fracture where a partially edentulous mouth, because of no teeth is present, the fracture the propagation of fracture line is through and through from bicortical plate, and it has led to detachment in the edentulous area, that is class 2 fracture. And class 3 fracture again is that fracture which occurred in the completely edentulous mouth. So any fracture of class 1, class 2, class 3 could be single, green stick or comminuted. So most of the time the green stick fracture is not seen in class 2 and class 3, because green stick fracture occurs in dentate patient when the children are in mixed or complete dentition. Okay. So now coming to the management. How do we manage a fracture? The major goal of management of fracture is close reduction, always reunion of the bone, cutting back to its normal anatomical position so that the functional which is impaired has to be re-established. So what is the function that is getting impaired? The function that gets impaired is temporomandibular joint. See, any fracture, whatever, wherever in the location of the mandible it occurs, it affects the temporomandibular joint. Why it affects the temporomandibular joint? Because temporomandibular joint is a dynamic structure which is attached to the part of the temporal bone with the help of condyle to the mandible, so that mastication, speech and all those activities which a mouth can take place can be maintained. But what happens when any fracture occurs? When the fracture occurs, there is impediment of the movement of the mandible. When there is an impediment of the movement of the mandible, what it leads to? It leads to impaired in the function. So speech is hampered, food is hampered, patient cannot masticate the food because the mandibular fracture, the fragment is moving independently. It is not in control of the other muscles of mastication, the accessory or the major muscles of mastication. Maybe it has hampered unilaterally or bilaterally. Okay, so restoration of goal of occlusion is most important. Occlusion is established, the function is established. The function is established, naturally the anatomical location of the fragments are in its correct position and it has emphasized itself from non-favorable to favorable condition. Repair within a week so that the health condition cannot be deteriorated. In generally favorable fracture is only needed close reduction. See, just now what I have discussed was all those fractures which are favorable in nature undergo with close reduction. Now what is close reduction? What is open reduction? Close reduction is one of the reduction which see, in mouth we cannot put a plaster. Okay, when a fracture occurs in the hands, legs, what you have seen is that when you do a close reduction, they put a plaster band so that immobilization is prevented. But in mouth, we cannot put a plaster because you cannot breathe, you cannot drink, you cannot eat. It is completely affected. Now, what to do? How to impair the movement of the mandible? So, close reduction, IMF, something which is called as intermaxillary fixation or maxillomandibular fixation technique is being done, and which we are going to discuss later on. Okay, so that technique is being used for impairment of the movement of the mandible so that the bone should heal, and within a week or so the patient can rehabilitate it to minimum extent at least required for that patient to survive. Okay, in general favorable fracture only needs close reduction, post-operative care. Now that is what MMF. MMF is nothing but maxillomandibular fixation. It is a type of close reduction required when it is indicated. It is always indicated in condition where the fracture is under the state of favorability. Okay, when there is a favorability of the fracture line is in favorable condition, that time close reduction is advisable. Second, what are the methods to be implemented to put a MMF? So the methods are variably different types of methods are arch bar placement, Risdon wiring, normal wiring, interdental wiring. All those techniques are being used, methods are being used for immobilization of maxillomandibular fixation. Nowadays, maxillomandibular fixation is done with orthognathic implants, which is being placed in a particular region, and a wire is being closely tightened so that the movement of the mandible is restricted. Okay, typically maybe this type of treatment requires 2 to 8 weeks. Okay, for removal. And what are its complications? Complication is impairment of the mastication or food habit. Now in this image you can see the maxillary and mandibular bone is held in its position with the placement of an arch bar. This arch bar is placed with the help of presence of dentate patient, which this treatment can be done only in dentate patient. Edentulous patient, this treatment is impaired because arch bar placement requires tool. Now arch bar is being placed in its position with the help of ortho wire. Okay, there are wires which are being used, like this is ligature wire is used normally. The ligature wire is placed in its position, the arch bar is tightened into its position, both maxillary and mandibular. After tightening of the position, the mouth movement is being restricted by placement of bands. Okay, coming to open reduction and internal fixation. Indication, when it is indicated. So now open reduction is done when there is unfavorable fracture, but the fracture line is certain times open reduction gives more benefit than that of the close reduction, because the patient need not to be having closed mouth for a very long period of time, like 2, 3 to 4 weeks or 5 weeks. Okay, 5 weeks the patient mouth opening is restricted, but whereas in open reduction and internal fixation with a compressive plate, a patient within a span of 1 to 2 weeks he can slightly open his mouth, the function can be re-established, movement, though mastication is impaired, soft diet is most preferably, semi-solid or liquid diet most commonly advised for the patient to take at the time when the for ingestion. Okay, now what are the approaches, how to approach for OSMF? So there is a transoral and extraoral approach. Extraoral approach is usually tried to be avoided because a scar is being formed onto the face. So maximum time intraoral approach, and is advisable. So the fracture line, which is an unfavorable fracture, is aligned and positioned into its required location. First, after location, a compressive plate, 2-hole, 3-hole, 2-hole, 4-hole plate, compressive plate is being placed into the bilaterally adjacent to the fracture line. As you can see here, this is a compressive plate. This compressive plate is being placed in its position, and the type of approach here is extraoral approach. So this is an extraoral approach. From the angle of the mandible, it is being exposed, and the fracture segment plating is being done, and after doing the plating, the mandible is closed back. Extra care need to be taken is that the facial nerve should not be getting damaged, and some lingual artery, all these anatomical structures have to be taken care before placement of the plate. Okay. Now this is intraoral approach. This is somewhat extra and intraoral approach of placement of the implant, because the fracture is at the angle of the mandible. So transoral approach is being advised for the placement of the screws. Okay, and with the help of the compressive plating, 1 or 2 plates are required. Most of the time it is 2 plates are required. One is a larger plate which we consider as 2-hole plate, and a smaller or mini plate which is 2-hole plate. This is 4-hole plate, this is 2-hole plate. So this plates is being positioned, it is adapted, it is bent, it is modified for adaptation onto the mandibular bone, and with the helps of screws it is being positioned, and the patient is left. After some time, the plate is been either removed, or most of the time it is left, because it is not causing any major complication, especially when it is titanium coated screws and plates. Now, management of types of fracture, like coronite, green stick, unilateral, non-displaced fracture, observation with softedite. Softedite is advised. Analgesics and oral antibiotics are being given. If in certain case where oral antibiotics is impaired, then intravenous antibiotics is advisable. Physiotherapy for 3 months is being given. Certain exercise is advised for the patient for slight movement of the mandible during healing phase, so that most commonly the callus is formed, which later get ossified to form bone, and the formation or union of the bone takes place. So all those things are when there is a minimal displacement of the fracture. Now, minimal displacement like non-condylar fractures, where condylia are not involved, the close reduction usually within the span of 4 to 6 weeks. With the help of maxillomandibular fixation, the segments are stabilized. There are other things, displaced fracture, simple, and I'll just complete this 3 segment, and maxillary fracture we'll discuss in later class. Now coming to management of displaced fracture. Now displaced fracture are symphysis and parasymphysis fracture. Symphysis fracture occurs at the symphytic region of the mandible. Entire mandibular bone is divided into 2 half, right and left half. So because this bone is formed by the union at the junction of the middle of the face, there are sutures present. This sutural area is slightly less ossified tendency. Any blowout fracture into the frontal region can easily detach the mandible into 2 halves, that is called as symphysis. And then comes the parasymphysis fracture. Parasymphysis fracture tends to be vertically an unfavorable fracture. Both segments get detached, and because of not proper ratio of bone, one side it is more, one side it is less, the displacement of the fragment segment is more commonly. Now the body fracture almost always unfavorable, because muscle attachment, the major muscles of mastication are attached posteriorly, so the body of the mandible get easily, because of the contraction of the muscle, they easily tends to move superior inferiorly, and causing the mandibular displacement of the bone. Angle fracture is generally having the highest complication rate and displacement. Then comes the ramus. Isolated ramus fracture are rare, but when it occurs, it also causes displacement of the fracture. Now surgical complication is what? When we operate a fracture in the mandibular region. Don't forget that the mandibular region, when there is a two fragment segment, the mandibular region has a mandibular canal. Mandibular canal has many blood vessels and nerves like inferior alveolar nerve, artery and blood. These supplies to the bone, so they may get detached or they may get affected, and they may lead to paresthesia or hypesthesia of the chin and lips. Okay. Now, second thing, it may causes infection because of comminuted fracture, and there is no blood circulation to the underlying bone. Certain time osteomyelitis, inflammation of the bone takes place. Malunion. Malunion. How malunion occurs? Malunion occurs very commonly because if suppose there is an head and neck injury or a pan-facial trauma injury. What happens? Whatever we are discussing here, we are discussing about a fracture which is at a particular location. But what happens when 2 or 3 bones are involved? Okay. So the patient may undergo syncope. Patient will be under coma for many years or many months. That time you cannot operate for the stability of the mandible. Usually other areas are very much important. So that is taken into consideration, and because of improper malunion takes place, non-union takes place, plate get exposed because of infection, or patient is not following proper instruction or proper tissue adaptation or less tissue presence or inadequate material required for proper closure. All this may lead to plate exposures. And then comes the mandibular nerve injuries. Okay, then this is what, like just now I have discussed, the injury to the mandibular nerve will also cause loss of sensory and motor activity into the mandibular region, less than motor activity than sensory. Sensory is more commonly affected. Necrosis of the underlying structure like condylar structure, they get necrotized because of decrease in the blood circulation. Normally there is a decrease in the blood circulation into that region. As last class when we have discussed about the temporomandibular joint, I have discussed that the temporomandibular joint is a condylar complex which is present in the thinnest avascular portion in its respective disc. Now this avascular region, there is a contact of the temporomandibular joint. In that region already there is a divide of the blood circulation, and again there is a fracture, there is no proper blood circulation, there is no proper wound healing, and when there is no proper wound healing, there will cause need to necrosis of that particular tissue. Then temporomandibular ankylosis, because of impaired movement for many months, there is pseudo or true TMJ ankylosis takes place. Ankylosis is inability to open or close the mouth because of the effect on the temporomandibular joint. And comes the dental injury. Dental injury, loss of teeth, loss of function, also other complication. During fracture time, most of the time when we see that when there is an unfavorable fracture and that the fracture line is passing through the dentate or the tooth part, then what happens when you operate for a fracture fragment? The tooth interferes with that particular structure. So what happens? That structure, there is tooth which is not allowing or adapting the bone. So what we do? We try to exfoliate, we try to remove that bone. Okay. Now this is a partially edentulous mouth. What you can see is that there is a symphysis fractures that have occurred at the center part of the tooth. This is where the tooth is also maybe having the tendency to be lost. Okay. Mandibular fracture we will discuss in another class. Thank you.